Upstate Medical University in Syracuse, New York invites you to be the informed patient with the podcast that features experts from Central New York's only academic medical center. I'm your host, Amber Smith. An estimated 1 in 4 stroke survivors will have a second stroke within 5 years, and more than a third of second strokes are fatal. So post-stroke care and prevention is crucial. Here to talk with me about that are cardiologist Andrew Weinberg and vascular and interventional neurologist Hesham Masoud, both from Upstate. Welcome both of you to The Informed Patient.
Thanks. Thank you.
The two of you have worked on methods for reducing stroke risk for some of these patients, but before we get into specifics, I'd like to understand more about second strokes. I believe most strokes are ischemic, meaning they're caused by a blood clot obstructing a blood vessel in the brain, but some are hemorrhagic when a blood vessel bursts. So I'm wondering, are people with both types of stroke at risk for a second stroke? Dr. Masoud?
Yeah, and just to kind of frame it a little bit more accurately in the sense that it's about conditions. So conditions that lend themselves to a lack of blood flow. That's the majority of cases. So that can be a clot that obstructs, that can be obstructions of different mechanisms. So it's not always related to a clot. It can be other risk factors. And then there is the hemorrhagic, which is to say, these are conditions that lend themselves towards having too much blood there. And that can be bleeding into a space or a part of the brain itself. And that has its own risk factors. And that's 20% of the time typically. And so, yeah, like you intuited, oftentimes the cause of, God forbid, a second stroke is, consistent with the circumstances that led to the first stroke. And there's a variety of explanations as to why that might be.
Can you tell us how to prevent second hemorrhagic strokes?
It is the rarer of the two, but there is some interesting observations that risk factors for one are actually risk factors for the other, which is to say, there are modifiable risk factors like high blood pressure and diabetes that lend themselves very much towards a recurrence of either type of stroke, be it, lack of blood flow or too much blood flow. And then there are also circumstances that are intrinsic, or I should say specific to that part of the cause, which would be to say circumstances specific to rebleeding. And that might be something like a structural predisposition to having bleeds. And so I would say, generally speaking, the same methods or strategies that you would use to prevent strokes on one side are the same for the other in the modifiable realm, which is to say blood pressure control, good control over your blood sugar. The non-modifiable realm would be things like genetic predisposition to having something happen, or, the elephant in the room, which is age. And as we get older, our risks for all kinds of things go up.
Are you able to pinpoint the cause of most strokes, or are there some that are just of unknown cause?
It's a great question. And you can imagine with technology getting better and better, we're getting a better understanding of strokes in the past that we used to categorize as quote unquote unknown. And this is where a lot of the work that Dr. Weinberg and I have been doing recently has to deal with this idea of surveillance to capture events in patients who had typically been categorized as unknown stroke. So that group of, at the end of the day, we've done our first assessment and not found a readily available cause. That's around 30% of the time that will not exactly have a direct attributable cause. We might know the mechanism of the stroke. So we know how it was expressed, but we might not know exactly who expressed it. And so that's a nice differentiation of knowing a mechanism, but having a partial a lack of awareness versus not knowing both, which used to be the case. It used to be on a lot of cases, we didn't even know how the mechanism of this expressed. And then we have now MRIs, which tell us about the pattern, and then associating that pattern with risk profiles allows us to stratify. Now I know how the mechanism was, and now I'm looking at cause.
How often does atrial fibrillation play a role in strokes? Dr. Weinberg, can you start by describing for us what AFib is and how it can cause a stroke?
Sure, happy to. What we call AFib stands for atrial fibrillation, right? So if we break down the words themselves, Atrium or atrial refers to the atrium, which is the top two chambers of the heart. The heart has its own electrical system. We know that the electrical system starts with the contraction of the atria, and then eventually the ventricles contract, the heart beats, the signal travels from top to bottom, and then that's the electrical representation of a heartbeat. So that's where the word atrial or atrium plays in here. Fibrillation is just a fancy word for shaking or quivering. So when you're in a normal rhythm, the electrical signal is traveling. I explain it to patients as an assembly line, that the electrical signal is traveling from point A to point B and point B to point C. Those points have more scientific names, but for this discussion, we can just call them points. And when you're in a normal rhythm, the electrical signal is traveling normally, right? When atrial fibrillation, when you get a shaking of the atrium or a quivering of the atrium, your electrical signal is not going to, you lose that normal relationship and that normal travel of the signal. And instead, the heart starts to quiver or shake. And as a result of that process, because remember, blood is constantly flowing in and out of our hearts many, many thousands of times per day, what can happen in the setting of atrial fibrillation is because the contraction or the beating is not as efficient, blood can clot in the heart, break off, travel, and go up to the brain via, there's 3 arteries that connect the heart to the brain, more or less. And that's usually the mechanism by which atrial fibrillation is related to stroke.
Dr. Masoud, you were going to say something about strokes and atrial fibrillation's role.
Yeah, I think, a lot of the times we'll find a quarter of strokes are related to atrial fibrillation. In that subgroup that you had asked about where we don't know who exactly caused the stroke, but we know how it was caused, when we look for monitoring, we find around 16% of those can be related to atrial fibrillation. So atrial fibrillation is a major player in stroke risk and is why it's a high yield target for prevention and is something that is fairly prevalent in our aging population.
This is Upstate's The Informed Patient Podcast. I'm your host, Amber Smith. I'm talking with Dr. Andrew Weinberg, who is a cardiologist at Upstate, and Dr. Hesham Masoud, who is a vascular and interventional neurologist at Upstate. And our subject is reducing the risk of a second stroke after a first stroke. So, Dr. Weinberg, would a person feel that quivering that you described? Is that how they would know or how they would learn that they have AFib to begin with?
So the answer to that question is maybe. It can be a bit frustrating. Not all people with atrial fibrillation are symptomatic. Okay. So there's lots of differentiations within the world of atrial fibrillation, but one of them on its simplest form is asymptomatic. Asymptomatic meaning absence of symptoms. And if you can imagine in the setting of a stroke, there's a lot happening all at once, right? There are stroke-like symptoms, and it may be difficult or nearly impossible to know if you're in atrial fibrillation at the time of a stroke. Most people it would be very difficult for the person to know that. The other thing I will mention about atrial, so to answer your question, no, you can have no symptoms at all and be in fibrillation. We do see that. The other difficult part of catching atrial fibrillation is its nature, meaning we deal in the atrial fibrillation world and in the electrocardiogram world in seconds or milliseconds of time. To be in atrial fibrillation for 2 minutes, 5 minutes, an hour is very long or can be long. The heart rhythm can change second to second, minute to minute, hour to hour. So as a result, a patient can present in atrial fibrillation with a stroke, have no symptoms, be out of atrial fibrillation by the time some type of diagnostic modality, let's say an electrocardiogram, is performed, and you wouldn't know that the person was in atrial fibrillation, which we'll get into this, which is why we look towards long-term monitoring. So as a result, to try and catch or document the presence of atrial fibrillation in the setting of stroke or recurrent stroke.
Do you ever see patients who have a stroke and then develop atrial fibrillation?
Yes, quite commonly in this which we call cryptogenic stroke that Dr. Masoud described. People can have no prior history of atrial fibrillation, or that they're aware of. And then after the fact, or while we're evaluating the stroke and trying to figure out a treatment plan, we diagnose atrial fibrillation. So yes, I do see that.
And Dr. Masoud?
Yeah, sometimes, and not infrequently, some of the larger clots that require us to physically retrieve them will be in cases where there is new onset atrial fibrillation, which is to say they present with a large stroke and the need for a clot retrieval and the first evidence of atrial fibrillation in the emergency room being detected. So yeah, it is a link to the disease.
What symptoms do you tell patients to be on the lookout for in terms of, stroke risk if they have atrial fibrillation? Is there something that they need to act on quickly if it happens?
Well, stroke is really the manifestation of that end outcome of the brain not receiving the delivery system it needs. And that can be related to either a lack of blood flow or too much blood flow disrupting that transfer. And so really that's your indicator that something's wrong, outside of obviously the specific symptoms that Dr. Weinberg reviewed related to some of the feelings that you might have as a result of the circulatory system's effect related to atrial fibrillation's irregular rhythm and how that might make you lightheaded. But from a stroke standpoint, it's very much if there is any sudden subtraction of function, that's an indicator to really get seen immediately. And whether it improves or not is almost irrelevant to that instruction.
I know a lot of people who survive strokes are put on blood thinners afterward. Is that enough to help prevent a second stroke in people who have AFib?
I mean, it's a big player in reducing the risk. And so it is a big part of what drives the diagnostic decision-making, which is toward the end of looking for an opportunity to get someone on a blood thinner if they need it. In this specific realm of atrial fibrillation being a very high yield target. But it is worth saying that there are other risk factors within the profile of someone that has atrial fibrillation that also have a play in the recurrence risk and or the risk of atrial fibrillation being directly causing strokes. And we have a score for that. We call it the CHADS VASC score, and it includes some variables related to the expression of disease in that patient related to high blood pressure, heart failure, diabetes is a big player, other vascular diagnoses. And like we talked about, the elephant in the room, which is that we continue to age with every year that passes. And so these are risk factors, some of which are modifiable outside of the prescription of a blood thinner that directly play a role into the recurrence of stroke risk tied to atrial fibrillation and otherwise.
Dr. Weinberg, in addition to blood thinners, what are insertable cardiac monitors? Are those used with blood thinners or instead of?
One of the biggest clinical questions that I have to answer or address in the setting of atrial fibrillation, there are many, but if I had to come up with a top one or two, it is, do I need to take a blood thinner? And if so, for how long, right? It is easy to prescribe, but you have to be aware and know what the risks and benefits are of that decision. We are trying very much in multiple arenas to basically streamline care, and not because it makes us feel good to put someone on a blood thinner. There should be a calculated risk benefit discussion. And implantable cardiac monitors, just to back up for a second, we have multiple ways to monitor. There are short-term monitors or external monitors that patients can wear anywhere from 24 hours to 30 days. And we do often start with this as a first modality in an effort to detect atrial fibrillation in the setting of a stroke. But as you can imagine, 30 days may not be enough because we don't know exactly if someone's going to have atrial fibrillation. We don't know when it is going to occur. There's no reliable, it happens in 8 days post-stroke. In fact, the data will show that The average length of time to detect atrial fibrillation in the setting of a stroke is 88 days. So if you think about it, wearing a 30-day monitor is most likely not going, if you follow those numbers, is most likely not going to elicit or give you the diagnosis because it's not enough time. So as a result, we look towards implantable cardiac monitors. I'll describe them a little bit. They're about the size of a USB drive. They used to be much bigger. I would say triple the size, but due to modern engineering and technology, we've gotten the size down to about the size of a USB drive, roughly about, and they can be inserted in an outpatient setting, such as in my office. They can be inserted in a hospital. And what Dr. Masoud and I have worked on together for the last 4 to 5 years is expanding the network of patients being able to receive implantable cardiac monitors. Obviously, we've lived through COVID and lots of different health challenges. And this procedure is being done in 2 of our hospitals in the upstate system and 2 of our offices. And what we've also expanded upon is the number of implanters that are available to do the procedure.
Let me ask you, does it get put in the heart or next to the heart, or where in the body does it go?
So the heart is located on the left side of the chest. Okay. It then angles down. Think of a 45-degree angle on the left side of your chest, kind of headed in the direction of your left hip. Okay. That's where the heart is physically located. This monitor does not go into the heart. This monitor sits in the subcutaneous tissue or basically right under the skin. Okay. And then communicates due to its proximity with the electrical system because just like we do an electrocardiogram where we look at the electrical activity by putting stickers and then attaching those to a machine, think of the implantable cardiac monitor as the electrocardiogram sticker, which gives us proximity to the electrical system and then allows us basically a look into the patient's electrical system from a less invasive approach. We're not going into the person's own heart or electrical system of the heart.
How long does it last?
So they do have a battery life of approximately 4 years. In terms of how long we keep it in, it is obviously the person's preference. So first and foremost, this is someone's body. In general, my practice, if you go based upon the 88 days that I told you, plus the unknown nature of when atrial fibrillation is to show up, I usually recommend leaving the implantable monitor in for the length of the battery life. And then there can be a discussion about whether to remove the monitor, keep the monitor in. The monitor does not have to come out, but it can come out. But if the patient desires to have the monitor out before that 4-year window, then that's certainly a possibility as well. Just knowing that once the monitor comes out, we're not going to have the ability to look for the cause of stroke.
So how effective are these implantable monitors in detecting AFib? Or I guess they could also pick up other arrhythmias, right?
Correct. So in addition, we live in the world of artificial intelligence, and artificial intelligence has been incorporated into the implantable cardiac monitor as well. We have to be careful when we implant these monitors because you don't want to falsely tell people that we will record everything and we will see everything. We don't see everything, but we see what we need to see, basically. So yes, fast heart rhythm problems, slow heart rhythm problems, pauses, which are temporary delays in the electrical system. All of this can be detected by an implantable cardiac monitor, even if the initial indication was to look for atrial fibrillation. So it does open the door to the detection of other arrhythmias. But in terms of the accuracy, again, we use our artificial intelligence, and they're over 90% accurate in detecting atrial fibrillation. Again, nothing is perfect, but again, they have to be analyzed. I have a team that I work with in my office, a dedicated nurse and a nurse practitioner who analyze the data that we receive from implantable cardiac monitors. You can't just believe everything you see, as the expression goes, but we look at it, we review it, and if it is truly atrial fibrillation, then we come up with a treatment plan in conjunction with our neurology colleagues to best treat the patient.
Now, these days, there are more and more wearable devices that monitor all sorts of health effects. Is there not something out there that would accomplish this that's a wearable device instead of an implantable device?
So the wearable devices have, as you mentioned, Amber, we've seen a lot of them explode on the market recently, and they are helpful, in my opinion. And again, I don't want to veer this to an engineering talk, but my concerns with the wearables are the diagnostic accuracy of the device. To provide an example, one is what's called a cardiomobile app, where you put two fingers on a little application and then get a rhythm strip. If you're nervous and you're shaking, and if we can't get a clear idea, the electrical signal in the heart is small. It's not a huge image. So if we can't get clear data, it's difficult to make a big decision about being on blood thinners, what to do from artifactual data, which is basically data that we can't interpret. And with an implantable cardiac monitor, in my opinion, the data is typically a lot clearer, because they try and filter out artifact and false positives. And they've really done a great job of trying to eliminate that, because we don't want to look at information that's not going to have a clinical impact, meaning that's going to help us make decisions, right? We want to look at good data that makes sense, that fits. We don't want to waste our time and a patient's time by looking at data that's not helpful. So wearables are an option. Some people want that, and that's what they prefer. But I think if you ask most of us, the accuracy of an implantable cardiac monitor, and you have it in long term, right? That's the other thing, right? A wearable, you have to put it on, right? Sometimes, versus having something in. So that would be my answer.
This is Upstate's The Informed Patient podcast. We're talking about reducing the risk of a second stroke after a first stroke with cardiologist Andrew Weinberg and vascular and interventional neurologist Hesham Masoud, both from Upstate. So I want to understand what the two of you started working on in 2022 regarding these implantable cardiac monitors. Dr. Masoud?
Yeah, I mean, it was really born out of the organic service line needs, and really specifically the inpatient stroke service line. And like we had talked about, there's, 30% of these patients that could benefit from prolonged heart monitoring. And the best standard of practices for that endeavor are to use an implantable loop recorder. So that's one thing to highlight, is the method that we use in our diagnosis has to be stuff that is clinically validated to that purpose. And while technology in the commercial space may yield a future of equivalency, it has not been verified to that end. And these are high stakes decisions. So, we needed to have a streamlined process to how we deliver this standard of care. And it required us to have someone implant the device. And that was really a bottleneck that we had identified related to it being siloed under a specialty service provider. And then Dr. Weinberg and myself looked at the best ways to sort of democratize access to this by creating healthcare redundancy, which is to say training providers who have domain knowledge to be able to understand the context and the decisions that led up to the insertion of the device, such that they can provide informed consent, and also have the transferable psychomotor skills to be able to do what is essentially a bedside procedure that can be done in an outpatient setting in terms of the level of sophistication. And so that's what we collaborated on, going through iterations of training myself and training other providers in a scaffolded way.
So who is actually doing the insertions, and would it be on patients before they leave the hospital to go home after they've had their stroke, or would this be done when they come for a checkup afterward?
Yeah, we tailor it to the patient's needs. You can imagine there are advantages to implanting the device inpatient for patients that might not have the ability to return. There's also the advantage of having uninterrupted data collection in this regard. And so we try to facilitate care as much as possible to that end.
So this is about a third, roughly, of people who survive a stroke might be recommended for this.
Yeah. And really, to answer your question about who's doing the implant, well, we really wanted to target the most consistent presence in the inpatient care of a stroke patient. And that's really with our nurse practitioners who handle, as you can imagine, a lot of the overlap of nursing care coordination and higher level understanding that they have as being advanced practice providers with training in this space. And so we have multiple providers who are trained, including MDs, and our primary driver in terms of what Dr. Weinberg and myself have been pushing is sort of training up nurse practitioners, because that yields the most healthcare redundancy as it pertains to capacity building.
Are there any patients for which this is not recommended? I mean, are there some that are just not candidates for having an implantable?
There's always patient preference that's respected. We're talking about surveillance here. So it is a shared decision making at the end of the day, and not like, someone refusing to get penicillin, which we would try to obviously talk someone into, because it would be a fairly straightforward value proposition. So things like that. But for the most part, it is not a procedure that yields much of exclusion in terms of its complexity. But, you can imagine, related to the battery life, you may not want to implant that in someone who has some frailty and maybe some longevity there and end of life care.
What percentage have detected atrial fibrillation?
In our cohort where we've implanted these with nurse practitioners, it's just over 100 of these. It's been somewhere in the realm of 10 to 20%, which sort of lines up with what we've seen in evidence.
And then the nice thing with having a cardiologist involved is, because then if you find atrial fibrillation, you then need to deal with the treatment of atrial fibrillation, which obviously you're moving a little bit from the stroke realm into the cardiology world. So as Dr. Masoud mentioned, having the APPs trained, there's a very nice dialogue between myself and the stroke faculty, and we coordinate this care pretty seamlessly. We get these patients into the office once we have diagnosed something to go over it and outlining the treatment plan going forward.
Well, that's encouraging. And given that the risk of, dying from a second stroke is so high, this seems like it is definitely life-saving, right?
It certainly has the potential to be saving from a significant disability. The strokes that come from atrial fibrillation are some of the most disabling strokes. They're strokes that are associated with the largest size of stroke fingerprints that you would see on an MRI. So when these happen, they tend to threaten and take out large territories of brain. They tend to be clots that don't dissolve easily with clot busting drugs and require removal. And so absolutely a very high value proposition to prevent strokes of this variety.
I want to thank both of you, Dr. Masoud and Dr. Weinberg, for making time for this interview.
Oh, a pleasure.
Thank you so much for the opportunity, and we're grateful that we can get this information out to our patients and community. So thank you.
My guests have been cardiologist Andrew Weinberg and vascular and interventional neurologist Hesham Masoud, both from Upstate. The Informed Patient is a podcast covering health, science, and medicine, brought to you by Upstate Medical University in Syracuse, New York, and produced by Jim Howe, with sound engineering by Bill Brokel and graphic design by Dan Cameron. Find our archive of previous episodes at upstate.edu/informed. If you enjoyed this episode, please invite a friend to listen. You can also rate and review the Informed Patient podcast on Apple Podcasts, YouTube, or wherever you tune in. This is your host, Amber Smith, thanking you for listening.